Welcome to another episode of Surviving COVID-19. If you're watching this right now, you are indeed a survivor, but you've also missed 6 other shows. Fortunately, you can find them all on my YouTube channel. Just look for Israel. Now, concerns have come up about Ghana's response to the coronavirus pandemic in recent weeks, especially with regard to testing. For some observers, including myself, who I'd want to describe as COVID-19 watchers, the significant reduction in the number of samples being tested is worrying, considering that we used to test as many as 12,000 samples in a day when there were much fewer cases. The samples being tested now, however, around 1,200. We've heard of situations where hospitals say they've sent samples to testing centers, but haven't had their results. And yet we see those regions listed as having no active cases. If the results of these tests are not being released, or the tests are not being done at all, it would be misleading to say there are no active cases in those regions. Having said that though, carefully look around and you'd realize many are not observing the COVID-19 safety protocols in our markets, offices, and out there in the streets. For the markets especially, I wonder why we're not hearing that half the traders and market women have come down with COVID-19 and so are unable to come to trade or that people who went into the market to buy have fallen ill after picking the virus. As for the political gatherings, let's just say we'd have to wait a while for the impact. That is, if it actually ever will. Our hospitals, as we're learning, are also not overwhelmed, which, as Dr. Godfred Techi of UGMC told us a couple of weeks back, is consistent with a decline in active cases reported by the Ghana Health Service. That's why I have as the topic for today the question: is the SARS-CoV-2 virus disappearing, hiding, or we're simply not seeking for it? And I'll introduce my guests shortly. My guest for today, Dr. George Kyei, a senior research fellow at Noguchi Memorial Institute for Medical Research, who is currently director for research at the University of Ghana Medical Center and has been involved in COVID-19 testing and research at Noguchi since the pandemic began. He will be sharing with us some of the interesting research findings they've gathered. Dr. Benedict Calys-Tagoe is an epidemiologist and senior lecturer at the University of Ghana Medical School. Thank you very much, Dr. Calys-Tagoe. And then we also have Dr. James Dua. He's the Deputy Director of the Christian Health Association of Ghana, another epidemiologist. He was on the show a couple of weeks ago. He hasn't joined us yet, but we're expecting that he will join us in a bit. We also going to be joined by Dr. Franklin Isiedubekwe, the head of disease surveillance at the Ghana Health Service. Thank you all for making time. Indeed, I find it gratifying that you honor my invitation each week. I don't take it for granted at all. I also want to say a big thank you to the Star Ghana Foundation and their funding partners, UK Aid, DENIDA, and the EU for supporting this initiative. I'd love to see others get on board as well. Now, we would get on with our conversation shortly, and I'm going to go straight to Dr. Godfred Kyei. He is going to start the conversation for us. Thank you very much once again, Dr. Kyei, for making time to be with us. Now, as I stated in my introduction, out there on the streets and in our markets, there are a lot of people who don't observe the COVID-19 protocols, mainly the wearing of face masks. Indeed, some research done by the Ghana Health Service confirms that. I can imagine that if one observes this in their environment, sees the decline in active cases, and knowing that their colleagues at work or at the marketplace or the people around them are not falling ill, they will come to the conclusion that COVID-19 is disappearing. So they can also ignore the protocols. What do we say to such people to convince them that they still need to observe the protocols?
Thank you very much, Israel, for this opportunity. Yes, so it is definitely not disappearing. So everyone will be encouraged to observe the protocols. But as you said in the introduction, the question is why do we have very low numbers at this point? It could be that we are not testing enough. It could also be that the market women you are talking about have had it and they did not get any symptoms, and therefore they are somehow protected from the virus. It could be that the immunity of Ghanaians or other parts of Africa is kind of different from other places, and therefore people here are able to control the virus. That could be one of the main reasons. It could be our very young population, which is protecting us from the virus. As you know, it gets more severe in the elderly who are likely to have comorbid conditions. And the median age in Ghana is about 20 years old, whilst that in Spain, for instance, about 45 years old. So that can make a huge difference in a virus that disproportionately affects those who are older. So there could be many reasons why we are not seeing a lot of people sick. But that does not mean that we are out of the woods. And I think that we can talk about other reasons why we are not out of the woods yet. I think you probably want to get to other speakers. So I will come back with some reasons why we should keep following the protocols that has been instituted by government to make sure that we don't get a spike in infections. But
Right.
these are some of the reasons.
I know that you've also done some research. You're privy to some research that has been done, and I'd want you to, at some point, share with us some of the findings. Now, if I can have Dr. Benedict Calys-Tagoe show up on screen with his video, then I'd also want to put the same question to him. Doc, thank you very much once again. So what's your take on all of this? Do you think the virus is disappearing, or it's just hiding to strike at us when we least expect?
Thank you very much, Israel, for having me, and good morning to all listeners and viewers. Well, I think Dr. Kyei has said most of the things I would want to say, but I just want to add that I agree perfectly that the virus has not disappeared. There may be a number of reasons, some of which have already been alluded. And let's not forget the fact that even for those who have tested positive, the greater majority showed no signs and symptoms. So we could have people still carrying the virus, not having severe disease that would warrant visiting hospital, not showing any signs and symptoms. And because our median age is that low, we seem to be enjoying that advantage. But let us also not forget, evidence that is available from history. If we look at the Spanish flu that occurred over 100 years ago, it followed a similar trajectory, and it occurred in 3 waves. At the end of the first wave, there was seemingly decline, the restrictions were eased, and the second wave hit them with a vengeance. History tells us that the number of deaths and the number of severe cases were much more during the second wave of that pandemic. And in total, even at that time, over 500 million people got infected with over 50 million deaths. And I bring this up because it shares similar characteristics with COVID-19 as we have it. No known cure, no known vaccine. The only things we have to protect us are the non-pharmaceutical measures of physical distancing, hand washing, hand sanitizing, etc., including the wearing of face masks. So they seem to have a lot of similarities. So I would want to be guided by history as we go along. Thank you.
All right, and I'll come to you, Dr. James Dua, who's also an epidemiologist. Dr. James Dua, what's your take on the question?
All right, thank you very much, Israel, and let me say good afternoon to all your viewers and listeners. Yes, sorry I came a little late, but let me say that as the other speakers have said, because a lot of people don't show symptoms, even those who have tested positive, it is possible that we have quite a number of cases that are not, let me say that in the rural areas and in the other regions aside Accra and Kumasi, if we were testing aggressively as we started initially, probably that will give us a true picture of whether or not we have the cases and the case counts is going down. But without having given everybody opportunity to test, including all the other regions, we cannot at this point say confidently that the case count is going down or the virus is disappearing. For my network, which is the Mission Hospitals and clinics, I am aware that there are quite a number of places where they want to test, but because of this, they are not able to. And even for those who have taken samples already and sent to the testing centers, we have as many as 600 test samples that are still pending. So those ones have not come yet. So I would say that testing is one of the reasons why probably the case count is we are not recording high as initially we were. Before we can conclude, we need to give every region and every district the opportunity, everybody who wants to test. If we have all those opportunities and the case counts are still down, then we can confidently say that the virus is disappearing. We also have examples in other countries. If you take the case of Italy, where initially they were recording high mortalities and high case counts, when they were lifting the lockdown and easing the restrictions, one of the biggest fears for the country was whether or not they will have, a rebound. But the contrary happened. After easing the restrictions, the numbers were down. The hospitals that anticipated that their beds will be occupied, we didn't see that situation. And so there are examples. And I think that in Ghana too, one of the things that may have helped is the fact that, we have widely accepted the protocols. If before this time, if you went to some of the communities, you will find that people are not wearing face masks. But now, if you go to most of the places, you find people, even women, wearing face masks and observing physical distancing and using a lot of alcohol-based hand sanitizers and all that. So there are multiple factors, but I agree with all the speakers that we are not out of the woods yet. We need to still be cautious. Thank you.
All right, so, but I want to stay with you a little while. Let's say we're not doing enough tests. If we're not doing enough tests, the people who throng the hospitals would expose us. Isn't that the case? Or shouldn't that be the case? Or in our workplaces, we're going to see that people are falling ill, and so they've had to go home and they are not available to work. But we have virtually everybody, almost everybody around, Dr. Dua.
Well, I think it's one of the things that is still not known about this virus. In Ghana, if you look at our cases, a lot of the people are asymptomatic. If you even take the health staff for my network, we've had quite a number of staff who have tested positive. So, yes, I guess if it were the case that people are becoming symptomatic, that will push the health staff to say that, yes, there's demand for testing, let us test more. But as long as a lot of people are asymptomatic, it will not, push people to say that, yes, even though we are not testing enough, we need to test more. I don't know what the others think, but this is the picture that I see. People were becoming more sick, it will push a lot of people to test. One interest that we have seen people who complain of, say, general malaise, and health staff think that this is a case of malaria. You do all the tests, you do rapid tests, count negative, and they test for COVID, and they are positive, So as I said, there's a lot that is not known, but we are grateful that at least a lot of people are asymptomatic. That is over Israel.
All right, I'll come to you, Dr. Benedict Calys-Tagoe. The same question I'm asking. Why is it that we're not having a lot of people being ill? Because, and again, I would want to believe that considering the numbers that we had back then, when we had fewer cases, we had people showing up in the hospitals. And yes, not everybody was mildly symptomatic. There were some who were asymptomatic, but yes, we also had some people who were mildly symptomatic, but they had to report to the hospital because they were not unwell. Why are we not seeing that happening now?
Well, it could be due to a number of factors. First and foremost, I believe as a nation, the level of risk communication and health education has decreased. We don't hear that much talk about COVID-19. We don't hear a lot of adverts on TV and radio as it was when this whole thing started. And that in itself has a way of affecting the health-seeking behavior of people. So if this noise is no longer being made, people who are asymptomatic or mildly symptomatic may not even think of COVID, because probably in their minds, COVID is gone. So that could be a reason why we are not seeing the mild cases in our hospitals. Bear in mind that over 90% of all our cases have either been asymptomatic or have mild form of the disease. So this is a major driving force that if people are not thinking of COVID, they would not report to be tested for COVID. And that could give us a reason to think that the virus is no longer there. But we need to know all the dynamics that are in operation so that we can put everything in perspective. Thank you.
All right, Dr. Kyei, you, from where you sit, you gather a lot of research. What are the numbers telling you? Is it really the case that we're not having people showing up in the hospital at all, or the numbers have declined significantly? What are your numbers telling you?
Yeah, thank you. I mean, from us at the testing center at Noguchi, for instance, we can only test what comes to us. The numbers obviously have reduced, and the positivity rate have also reduced. Now, remember that the Ghana Health Service is, I think, now focusing on those who are symptomatic and who go to a health facility to get tested. The enhanced contact tracing that we were doing in, is it May, June? That is no longer being done. But that in itself is not a bad thing. The thing is, as a country, we need to decide, how to manage, this kind of pandemic. Where do you want to put your resources? Do you want to go about testing 12,000 samples a day like we were doing in May, June, overwhelming the whole testing system in a disease that most of the people are asymptomatic? So I think focusing on those who are getting sick is very important, but the education should go out more so that those who have symptoms don't stay at home. So if you have any kind of symptom, show up and get tested. So I think that is what we should be doing so that we get more people tested and be able to find more of the cases that may be in the community. Now, the reason why this is important is that, a young guy who gets this or a young woman who gets this may not fall sick, but if, she doesn't know and she doesn't protect, she doesn't follow the measures, and she gives the disease to somebody else who is older in her own family, that may end up with that person dying, so, it doesn't disappear. We still have patients at UGMC, we still have patients in all of the other places, so it's here, and we should definitely make sure that we are following the measure. Another thing is that viruses can change, so maybe the strain of virus we have now, Ghanaians are able to control it well. Nothing is if we do not follow the measures to the extent that the infection rate in the community goes down drastically, then once the virus gets enough opportunity to replicate in or to multiply in many, many people, there's always a chance that it could mutate to a more deadly virus. So we should not be complacent in making sure that we follow the measures that have been put in place, because like Dr. Calys-Tagoe said, the flu pandemic is an example. The Spanish pandemic is an example. So this one, who knows, it could mutate, and the virus that may come out will be more deadly. And the mutation usually happens when the virus gets more opportunity to circle through many, many, many people. So the less people will get infected, even if they're asymptomatic, the better.
Right. I have my own uneducated theory about what problem may be happening, and I want to put it to you. Because you're the scientist, it's safe to share it with you, and then you can advise what it is that is happening. But I believe that we've also been joined now by Dr. Franklin Isiedu-Bequin. Dr. Franklin Isiedu-Bequin, it looks like you're driving, but I'd want to have your take on what we're talking about. Or before all of that, because you are in charge of disease surveillance, you have a better picture of what is happening. So you tell us, where is the virus?
Yes, thank you very much. The virus is in the country, just that I think that the magnitude of the virus has somehow gone down, and it's an issue that we need to unravel. So I tried to look at some data before I came, and to look at I look at from March to August. So I look at tests, done, cases, and deaths. And clearly, you see that in terms of tests done, our maximum was in May, and then July, and for August is a bit down. And then our maximum cases per month was also in the month of July, and then our maximum death was in June. So in terms of magnitude of numbers, August appears to have less tests, less cases, and less deaths. But I tried to look at this morning to correlate the cases as being reported and compare with those being admitted. And we tried to look at Accra being the epicenter. And I looked at the prominent areas for treatment. So I look at Ghana East, UGMC, Kolebu, 37 Police, Ridge, Tema, and Yahoo. And for treatment, the bed capacity is about 284. But from the information that I get, while I realize that now the occupancy has dropped to between, let's say, 80 to maximum of 100. And the available about 12 ambulances and 4 buses. But these buses are no more being actively used as it used to be. So it tells you that in terms of numbers and activity, quite a number has gone down. So if you want to compare, you can see that activity has dropped by about 100%. So the issue is it a real reduction or an apparent reduction? I think that clearly there's a real reduction in the number of cases. What I can foresee is that, you see, if you look at the cases in the country since March. In March, we were doing pure what I'll call routine surveillance. So cases were being detected based on the presenting complaints. Then in April, May, and June, we introduced what we call the enhanced contact tracing, whereby persons or localities of suspectable cases were being screened. So it was more of like community screening. So there's a large chunk of people who are being brought on board who were not directly likely to be cases. So that was the time that we had this large number of cases being reported. And that led to the introduction of more labs. Currently, as I speak, we have 15 labs on board which are testing. And all of these labs are actually testing. The only issue is that the quantity or the numbers being tested are very few. So that's a reality that has come. And I think that for us, the virus has actually reduced in quantity. Is it due to reduced virulence? Is it due to, I don't know, but something is happening now which tells you that the disease is not what it used to be last month. And clearly, if you look at the effective reproductive number, that's even reduced to less than 1 for the past like 3 weeks. So it tells you that clearly there's a reduction in the transmission of the disease in the country.
But you're unable to say exactly why this is so.
Yes, that's why I say that for now, we can look at the figures and say that there's a reduction. A reduction is not just because people are not testing, the numbers are not there. And you see, if we had more cases being reported at the health facilities and that's severe, then to give an idea that the numbers are being maybe hidden. But clearly, if you go to the treatment centers, they don't have the numbers that they used to have last month. So proportion-wise, it tells you that the numbers have reduced. That's why the numbers are less in that place.
You say that the testing, there are no samples to test, but we've had conversations where we know of some places where they're supposed to have 0 active cases, and yet they have samples that they're saying that they're not getting the results. They've sent samples to Tamale and they're not getting the results. I think that,
let's be specific. It's Upper East and Upper West. And I spent the last 24 hours speaking to Upper East and Upper West. Just 30 minutes ago, Upper West, you see, what happened was that, we had this issue about backlog that was evident about a month ago. And this backlog, you see, if you look at the new discharge policy, somebody who tests positive and if you are asymptomatic, after 14 days, you are clearly be discharged. So they had about over 600 samples that were sent to the reference lab in Tamale, that they had very few results. So technically, those people have been discharged, though they don't have all the results. But then I wanted to see if there was a big problem. We expect to see the cases in the hospitals, but there are no more cases there. So whatever happened in the past has been addressed. And then for the month of August, they submitted I think over 70 cases, and they said they have results for 46. So clearly, it is not that bunch of over 1,000 samples that's sitting there that we are waiting to get results that will change the story. So I think that for Upper East and Upper West, the 0 is 0.
Okay.
As it appears, though they had a problem of a backlog.
All right. Dr. James Dua is a member of the panel, and he has his hand up. I'm sure he has a question for you. Dr. Dua, I want to bring you in at this moment. You were indicating that earlier that we really we're not conducting enough tests. Dr. Franklin Sidubekwe says, well, there are no samples.
Well, thank you. I think Dr. Dr. Kyei did say that samples are not coming. You know, one of the things that I observe is that initially, because when you turn on TV and people were seeing death, especially in Italy and other places and all over, as Dr. Calys-Tagoe was saying, people were talking about it. There was that fear among the general public, and that fear was driving the demand for testing. And so you found that people will voluntarily go and test. Again, for prescribers, there was this high index of suspicion for cases. And so if you visit it with any symptom, one of the first things they will think about is to test for COVID. And so that high index of suspicion was also driving testing. But now, I mean, it's not as it used to be. The fear is gone. People are no longer dying. A lot of cases are asymptomatic. And that may not create demand for testing. I think the other thing is that, I mean, as I said earlier on, in some of the places, access to testing is becoming a challenge. And I can speak for some of the child institutions in rural areas. The situation is not high, but you have facilities who take the samples and then they have to pay for the transportation. For instance, if you are sending ambulance from Afrancho, somewhere Ashanti region BA to KCCR, and they have to pay about 200 Ghana cedis per sample that you sent. I mean, given the financial situation for some of the facilities, you wouldn't want to overburden yourself. And so the rate at which they used to send sample will obviously go down. So there are a lot of factors that are at play. That is not driving demand for testing. But I guess also for us as a country, looking at the amount of money that we are spending in testing, if one test is costing about $65, and we are doing all this number of tests, for how long can we go on? And I guess that's what Dr. Asiedu was saying, that we are not, the contact tracing, enhanced contact tracing is not as it used to be. It's also a lot of cost. These are some of my views. Over.
All right, Dr. Calys-Tagoe, you had your hand up earlier.
Yes. I've been listening to the submission of Dr. Asiedu Bequin, my very good friend. And I have a lot of questions running through my mind. Because when he says that the reproduction rate has decreased, how was that calculated? Was it based on the number of cases that were being detected? If you say that people are not reporting to the hospital, are we using hospital visits as an index? Because that would just be a measure of severe cases. And that would also be a measure of the health-seeking behavior of the people based on awareness created. So these in themselves have issues if we use them as our benchmark. And like Dr. Kyei said earlier, we should be mindful of the situation that it is possible that this virus may have mutated. And therefore we are seeing less severe forms of the cases, partly because we have a younger population compared to the Western world, and partly because the virus may have mutated. But it is also possible that as time goes on, this mutation may occur and we may start seeing severe diseases. If you go to the Ghana Health Service website, as at 20th of August, there have been a total of 26,548 cases from enhanced contact tracing and 16,957 from routine surveillance. So to date, even though the enhanced contact tracing has stopped for over 2 months, we have seen more cases when we were testing more. Now that we are not testing, can we confidently say that the virus is not there? If we say there are no samples to be tested, where are we looking for those samples? Are we waiting for people to come to hospitals? Yes, I agree. It is not possible to sustain that enhanced contact tracing. It is capital intensive. We cannot sustain it. But when we are not testing that much, then the way we interpret our data should reflect the limitations so that people would interpret that in the light of their limitations. But we shouldn't create the impression that there are no viruses because there are no samples to be tested, because we are not going for the samples. If we choose to test, people will be available to be tested. But now we are doing targeted testing, i.e. we are looking for people who are symptomatic and people who are high risk. If 90% or more of the people are asymptomatic, obviously there will be nobody to test if that is the regime we are using. That's my take.
Dr. Calys-Tagoe makes some fantastic points, and I'm giving you an opportunity, Dr. Franklin Dusier, to answer to the points that he's raised. Where are we looking for the virus? And I would also want to add, if we seem to have some excess capacity for testing, why are we not using that to do some enhanced contact tracing and testing? Dr. Franklin Dusier.
Thank you very much. Yes, so apparently, let me say that we are not saying that the virus is not in the country. That's one of what we are saying. And I think I spoke to you, last week or last 2 weeks, that for us, and I try to use the idea of this HIV and the use of condom. You see, the status of you is based on when you did a test. Because when you do a test today and you're negative, you are negative for only today. So this idea of test is good. But then you must know that how are you going to go about it? That's why I kept on pushing our agenda, our drive is to focus on the use of the face mask. That is what we have been saying. So we as a service, we have a clear priority that we are saying that we are prioritizing one, people who are reporting to the hospitals. So those are people who are classified as suspected cases. We are also prioritizing contacts of these confirmed cases. We are prioritizing exposed health workers, exposed students. We are prioritizing the detainees, and then at-risk groups. So not that we have stopped. And then if you look at the fact that we have stopped, we would have expanded the number of labs from 2 to 15. Now we have 3 private labs. We have Kyei, we have MDS Lancet, we have Yahoo, and they are all testing. So it is not that people are not testing. What I'm saying in reality is that the numbers have relatively come down, and it's obvious. So nobody has stopped any testing. Clearly, we as a service have prioritized that this is where we want to go. And there are a number of these banks or whatever who still go to Yahoo and go and test. So nobody has stopped anybody from testing. And I think that is the message we want to. But we want to say that testing is good because that makes you aware of your magnitude of the caseload. But we are saying that let's push for use of the face mask. That is a clear intervention that can actually minimize the transmission of the infection. So we are not saying that the cases are not there, but we are saying that the long term is about the use of the face mask.
Now, Dr. Calys-Tagoe also asked the question about on what basis are we talking? Were you saying that the arrow has gone down? What are the parameters you're using? Can you answer that too?
Yes, apparently, I think that is, if you look at what we are, nothing much has changed in terms of the country. If you look at the trajectory of the response, initially, as I said, it was purely suspected cases. Then we said that, and it was mainly people who are coming from outside. So about 90% of the cases were imported. Then we started having a few cases we were not sure, are they imported or community-based? Then we decided now let's do enhanced contact tracing to give us an idea of community spread. So that's why we decided to open up what we call community screening so that we can sweep the country, give us an idea of community spread. Now that is evident. Clearly, it's so obvious that the virus is in the country. So we don't more need to go and be sweeping. In that case, you need to be doing it on a daily basis. I don't think that's the way we need to do cost-effective interventions. We are saying that let's assume that the virus is a country, put in the necessary preventive measures to get not to get a disease, and that is the direction. Because if you, in that case, then the 30 million people need to screen them every day. Is that what you want to do for cost effectiveness? No. Let's prioritize, and the priority is, as I've listed, suspected cases, confirmed cases, confirmed contacts of confirmed cases, and this is what we are going. So we have never stopped testing, and I'm sure that the labs will tell you how much money. The private will tell you how much money they are making from the testing. The testing is going on.
Now, Dr. Calys-Tagoe, you have your hand up, but Kwame Siedu-Sapong has also joined us. He's a friend. I see him, I describe him as a friend of the show. He's been part of us from day one. So Kwame Siedu-Sapong, you've heard your brother, and I'm sure you want to react to that.
Well, I think Kofi struggled a bit with the R0 calculation, but he's correct. The point is the reproductive number has been dropping for the past 3 weeks. It is not consistently below 1. It actually has been fluctuating between 0.9 and 1.2. And the reason I suspect is this, because there's a direct correlation between the wearing of face masks and transmission. I'm looking at some data on our World in Data now, and it clearly shows that if you go through a 30% increase in the wearing of face masks, there is about a 5 to 10% drop in your reproductive number. And you can see that clearly in the Ghana data. And why am I saying that? If I look at the positivity test percentages, which I'm looking at now, which had been hovering around 22, 23% when I was last on the show with Kofi, it's been dropping consistently. I mean, in the last week, the running 7-day total is about 11.1%. And so what it means is that if you are doing a statistical sample, if you had 100 cases, when I was telling him point blank that I was very concerned about what was going on, almost 2 to 3 of the 20 to 30 of the 100 would test positive. Now it's between 11 and 15, which corresponds with the 50% roughly slowdown he's saying. My gut feeling is that that is happening because the epicenter is in Accra and Kumasi. And more importantly, the people in those areas are complying with the use of the face masks more than the other parts of the country. But here's my concern based on what I've said. Because of the political activity now, and with the people moving into the regions which are less exposed, there's a likelihood that because when they get there, and I've seen it with the NDC campaign and yesterday with the NPP campaign, they get there and you see people taking off their face masks, being interviewed and all that. And they are coming from the epicenter. If they transmit the viruses then into these deprived regions and this assortative spread starts, all these gains will be lost. And the data speaks to that. And that was what I wanted to say. So 2 things go for me here. The first is the reproductive number trend that I've looked at and the correlation with the positivity. But it also shows that there are peaks and troughs, peaks and troughs. Finally, the other thing is, like everyone is saying, our test has dropped by almost 1,300 a day. Kofi talks about cost effectiveness. I would err on the side of caution because when you're making a cost-effective decision, you also have to look at the prudence of the cost effectiveness. Dropping our testing by that much, is it prudent? The answer I don't have, but that gives me cause for concern.
What would you advise that, well, where should they be looking for the virus?
It's not about where to look, it's about the WHO guidance, which says that if your positivity test percentage is consistently above 5%, then you are not testing wide enough. But ideally, if it's between 3 and 12%, you are okay, you are plodding along correctly. I would rather we increase our test percentages to a point where we are more closer to the 5% mark than closer to the 12% mark. We are now just below the 12% mark. And that was why I was saying, because we were struggling with it a bit, but looking at the data, he was on the right track. We are below the 12% mark, but just being below the higher quartile is not a strategy because it doesn't give you leverage just in case political activity and all those things, schools reopen and human movement starts, you could quickly tip over the 12% mark. So we need to increase our testing a lot more so that this drops. Because at the end of the day, the factors and parameters that go into the calculation of the reproductive numbers, the major drivers are opportunity of infection and probability of transmission. If you look at the dots, that's the duration with which the first thing is the duration with which the person is infectious. Then the opportunity of transmission, the number of times either they are not observing social distancing, they are not wearing their face masks, they are not washing their hands correctly. Then there is the probability of an interaction resulting in a transmission of an infection. That depends on the person's viral load. It also depends on whether they are in places like a secluded place, or they are in the open and all that. And then finally, there's the susceptibility of the general population. And our susceptibility is huge because we are 30 million population, and I don't think even 10% of us have got the virus yet. So we need to control the O and the T seriously. That seems to be happening in the epicenters, but my concern is with the political movement. And that is why I'm saying that we need to increase our testing a bit so that the positivity can drop a lot more. So even if that happens, then when they have opportunity, the probability of transmission would not matter.
Dr. Calys-Tagoe, can we increase our testing a bit more?
Yes, thank you very much. So I think that you put a question to Kwame and Calys, that where should we be tested? I think that what we want to focus on is to make sure that our contact tracing is more efficient. You see, the idea is, and I think that we have a better way of doing it now. Now that we have more labs on board, the issue is, are we able to identify all the contacts? And are we able to follow them to the end? I mean, that one gets a lot more better results. I think this issue about WHO guidance, I think that your question is also very, very relevant. Where are we testing? If you decide to say you want to test, which people are you clearly tested? Do you understand? That's why we have prioritized. That's why I said we've never stopped testing. We're thinking that let's be able to get all the contacts and test all of them. Let's be able to be sure that we have all the health workers who have been exposed and test them. Let's be able to ensure that we get all the returnees. You see, so in that case, you are likely to get the people who have been exposed and likely to get the disease tested. And that is what we want to do. And then there are at-risk groups. So as I speak now, the upper east and the upper west one you talked about, they did enhanced contact tracing. That's how they had over the 500. So those things have never stopped. But I think that we'll still look at the avenues and areas that we need to expand our testing so that you can be sure of the numbers. We have never said that the virus has left the country. No. That's why we keep on stressing that for us, our main intervention is the effective use of the face mask. So we'll keep on doing the surveys. We have asked all the regions and the districts to be doing surveys that will encourage people that we are actually watching to see whether they are responding. To us, there must be a correlation between use of the face mask and the reduction in the cases. That one, then you are sure that you're on the right track. So I think that we have never stopped saying that we are not saying that the virus is not there. What is obvious is that there's a reduction in the numbers. And what is also obvious is that there's a reduction in the number of severe cases, which is obvious in the hospital. Thank you very much.
Now, you indicated that the health workers are being prioritized, but I'm getting a message coming through that health workers are not being prioritized. So you probably may have put in place a policy that the health workers should be prioritized, but really they probably may not be getting that attention.
So I think that I don't want to dispute it. What I'm saying is that is the direction of the service. There could be few exceptions, but then as far as we are concerned, we want to make sure that any health worker who's exposed is tested. Any student who's exposed is tested. And I think that it also behoves on the managers for institutions to ensure that it is done. I think that Dr. Bia talked about it. It's a bit more cost involving moving samples across. That is why we are saying that managers must also have it at the back of their mind that we want to test our staff. And I think that let's all work together in that direction, that our staff are our priority. And then not just going around testing people just because they are existing in your community.
All right, now, I know that you'd have to go. You're actually embarking on a journey. And so I would want to give an opportunity to the rest of the panelists. If you have any question for Dr. Calys-Tagoe, Dr. Benedict Calys-Tagoe, before he goes.
Yes, thank you very much. It's actually very refreshing to hear Franklin talk about the focus and the policy direction for the Ghana Health Service. My concern in all of this has been the risk communication. You know, if you are testing and you are targeting people, and then you come out to say that there are 4 regions with no viruses, or there are 4 regions with no cases, and yet we are depending on people complying with the protocol, the safety protocols, particularly the washing of hands and the wearing of the face mask. what message are we sending to the peoples in these regions? If the virus is not in our region, why should we wear the face mask? If the virus is not in our region, why should there be physical distancing? My problem has not been whether the service is testing or not, but it has been with the risk communication. It was in the president's speech, it was said by the director general, it was said by the head of risk communication. 4 regions do not have cases. What message are we communicating to them? And how do we convince people without cases to comply with face masks when we know that indeed the face mask helps in reducing transmission? So that has been my concern.
Risk communication, Dr. Franklin Zerubekwe. Dr. Franklin Zerubekwe. So Dr. Calys-Tagoe has a problem with the risk communication. Why are we telling some regions that there are 4 regions without any active cases? What sort of message do we intend to send to them when we do that? You'd have to unmute, please.
Can I make a comment whilst he comes on board?
Sure.
Yeah. You know, when we say active cases, these are people we have diagnosed. Now, for these people, if we put in the necessary measures, i.e. isolating them and treating them, they cease to be a threat because then we have reduced their risk of transmission. But let us not forget that there may be asymptomatic people in these communities who we don't know and therefore have not been able to isolate. And these people still maintain the capacity to transmit. And that is where the fear is.
All right, Dr. Franklin Zerubekwe, you can now respond to it. Dr. Calys-Tagoe is talking about the risk. What sort of message are we sending to people when we tell them that there are no active cases in their regions?
Okay, thank you very much. I think that the status of your country or your locality is just transient. I mean, you don't remain 0 forever. You are 0 for a reason. And if you look at the active cases that pertain, it is a fluid number. And normally when the president or the DG talks about, he says that it's being like that because people are adhering. So if you do not adhere to the protocols, then the numbers will go down. Because clearly the risk of getting the infection is there. It's just there. You just make sure that you minimize it. So if you decide not to wear any face mask, if you decide not to wash your hands with soap and running water or use sanitizer, and somebody enters the community with the disease, you can get it. So there's nowhere that anybody is preaching that you are 0, so you are 0 forever. Likewise, as I said, you are 0 for COVID or SARS-CoV-2 for that instant. You don't remain negative forever. So the status of an individual is just transient. And we keep on saying that if you look at our direction, it was to allay fear and also maintain calm. But it's an issue you need to play it carefully. Otherwise, people assume that the disease is not there. And I can say that our last survey, you can see that there's a slight reduction in the people who are wearing the face mask. And we are going to push the next coming weeks that whatever gains we are achieving now is purely because of the fact that people are adhering to the use of the face mask. And to us, that is our main intervention. The face mask wearing is the surest way to reduce the transmission in the country.
All right, thank you very much, Dr. Franklin Zerubekwe. I know you're not completely gone off because you'll be monitoring the conversation. I know you have to continue your journey. Now, let me come back to Dr. George Kyei. So, yes, we know that, or we all agree that we could do with a bit more testing. But if you look at the number of active cases, clearly, I think we can all agree that we're not having as many cases as we used to. So here's this theory that I've had in my mind for a while now. Could it be the case that the initial virus that came into the country through the imports was quite potent, but as it got transmitted through the community, its potency waned, and so yes, the virus is spreading all right, and yet it is not as potent as what originally came into the country. Dr. George.
Yeah, that is an interesting question, an interesting hypothesis. But the short answer to your question is we don't know. Now, scientists at Noguchi and Wagbib at the University of Ghana have done some sequences of the virus. Now, we did initial sequencing of the virus for the first few cases that came into the country. And then later on, we also took samples from around May, June, and did more sequencing. We didn't find any real difference, to say that, this particular mutation has happened, in the country to make the virus less infectious. I think that we are talking about face masks, I mean, I don't know whether I'm the only one seeing it, that a lot of people actually are not complying. When you go through town, I mean, you're not the only one seeing it. We all know. I mean, we can all see. It's obvious that people are not complying. Yeah. So, I mean, when you go through town, people are selling stuff. They are not wearing face masks. The ones who are doing well are those, in the established places like the banks, the established, the establishments which are more formal. But in the informal sector, you go to a fitting shop, virtually nobody is wearing a mask. So that is there. Now, your question, actually, I think the deeper part of it is, why is it that not more people are falling sick for this virus? And if you do, in various countries in Africa, they've done surveys, immunology surveys, to look at how many people have been exposed to the virus. And a lot more people, like in Kenya, for instance, they estimate 1 in 20 persons have been exposed to the virus because they have antibodies. In malaria, about maybe 12% of people were positive. In Ghana, surveys are being done now, which I can't say here, but I would say that the number is pretty large, for people who have been exposed. So when you say pretty large, what are you talking about? Maybe a ballpark figure, 30%, 40%, 50%? Not that high, but I would say that if the numbers that researchers are seeing now were saying that people are getting sick, the number of people who will be flooding our hospitals will be a lot. So there is definitely something that is protecting people around here, at least the majority of people around here. And various kinds of different hypotheses have been done. This is just opportunity for us to actually do the research to figure out, what is going on in terms of why people are somehow protected. So various people have talked about various things that could be happening, which include, apart from, of course, the age thing. Let's put the age thing aside. One thing people have hypothesized over the months is what we call education of the immune system by other infections. So when you get other infections, sometimes they don't only protect you from the disease, that you don't only get immunity from that disease, but you get immunity against other diseases as well. So for instance, there is clear data that when people are immunized for, let's say, measles, those children are protected against several other viruses and other diseases. And the general mortality for the children, irrespective of the measles, reduces. There is now some data showing that people who receive the measles rubella vaccine or the MMR vaccine seem to have some protection against the virus. So that could explain why a lot of children or younger people, even the developed world, children seem to be protected from this virus. So exposure to tuberculosis or the BCG vaccine has also been hypothesized. So all of these could be working in our favor. But again, that does not mean that we have to be complacent and let the virus run wild in our communities.
Dr. Calys-Tagoe, Dr. George Kyei talks about the fact that we need to research. What is stopping us from researching to find out exactly what is happening in our case? Dr. Calys-Tagoe, you'd have to unmute, please.
Yeah, can you hear me now?
Yes.
Yeah, so I was saying that when it comes to research, there has to be funding. And so if we really want to fund research, we should show commitment in that direction. As a country, what percentage of our GDP goes into research? I don't have the answer. I'm sure the politicians can tell us, but you don't research in vacuum. A lot of these researches that are going on are being spearheaded by individuals and some organizations and some donors somewhere. But as a country, have we put money aside for research into COVID-19? Did we factor that into the monies we received for managing COVID-19? I don't have the answers, but that is where we should be heading. Because if you look at, if what Dr. Kyei is anything to go by, if you have this huge number of people who have antibodies showing that they have been exposed, we are at a risk if any of these should start developing severe diseases. Bear in mind that the use of the face mask and the other preventive measures are not being enforced. And I don't see how even our law enforcement agencies can enforce this. All you need to do is to just walk through town. Not just those who are not using it, there are those who have it and are not. For some people, it is chin mask. For others, it is forehead mask. And I always say that leadership must always be by example. We have some of our leaders in this country, I don't want to mention names, but you see them always on their chin, talking from parliament. They wear chin mask. What message are we carrying to the populace? So if we want to work on this, it should be a holistic approach. If we want to go into research, you need to dedicate funds. You don't expect to get results from research when you haven't invested in research. And mind you, whoever is funding the research may have their own agenda. After all, he who pays the piper calls the tunes. So if government of Ghana wants data from Ghana to inform our management, then government should be willing to invest in research. If another organization from somewhere comes to invest in research, they have their own motive. There is no free lunch anywhere, and we should be mindful of that. So when it comes to research, we should show interest in research by committing funds to research. Thank you.
Dr. George Kyei, you have your hand up.
Yeah, I was going to support Dr. Calys-Tagoe to say that I think some of the COVID funding should be dedicated to research that is relevant for us. As remember, we changed our policies on recoveries based on the WHO recommendations. Now, if you look at the WHO recommendation and you look at the articles that the recommendation were based on, there's virtually none from Africa. Okay, and yet we are the ones who implemented the recommendations very quickly, So the question is, because for instance, there's a very important question, is that, for instance, people who have the virus, we say 14 days, most people are non-infectious. That is why they can go without another PCR test. Fair enough. Data from most places show that. But, the virus is not behaving the same way in Africa. If we have a low mortality rate of 0.6%, that means that there's something different here. And that something different need to be found out. And our data from our places should also help inform the WHO recommendations, and not just blanket take those recommendations. And it's not as if those research cannot be done here, but like Dr. Calys-Tagoe said, research is expensive. You can't just, for instance, if you want to see how long people actually shed the virus, you can't just do PCR tests like we are doing, because the PCR test just tells you that fragments of the virus is present. You have to actually do cell cultures of the virus to make sure, to find out that the virus you're isolating from the person can actually infect cells in the laboratory. That is how you determine whether somebody is infectious in reality or not. But these are things that we can do at Noguchi and other places. Another very important area that maybe I would say we should research into is, for instance, if you go to the outpatient clinics, a lot of outpatient clinics have slowed down, because of fear of COVID. And, people have estimated, and I think that is going to be the case, that in Africa, we are going to have more people die from other diseases aside from the COVID, because of COVID. So people with HIV who may not be able to go to clinic, people with TB who may not be able to follow up, people with hypertension, diabetes, and so on, who may not be able to follow up because of the fear of COVID on the part of both healthcare workers and the patient themselves too, So simple interventions that people have proposed, like mouth washes and so on, that could probably reduce the shedding of the virus, at least within a short period of time, could easily be researched, in various clinical trials. But, these have not been done yet. So these are simple things we can do that will help us to get life going, and also to make sure that the data that we are basing policies on actually apply to us, and it's not something that is always coming from Asia or US or Europe.
Now, Dr. James Dua, you are with CHAG, and CHAG being in most parts of, or focusing mainly on rural Ghana and parts away from the urban centers. Is there anything that you're picking up, or are there some ways you're finding out that we can actually avoid getting the virus? Could it be that some people are involved or using herbs, as has been suggested in the past, and for which reason it's boosting the immune system, and that's why we're faced with a situation where we're not getting as many cases?
Right. Thank you. I think those hypotheses are there. There are people who are saying some local drinks like attire in the northern region. You have many people who walk to the facilities and say that this local drink attire protects us. There are people who are saying sobolo. But I think it goes back to what Dr. Kyei and Dr. Calys-Tagoe are saying. We can only confirm what people say when we have done research with scientific basis to accept. Having said that, I think for us, one of the things that we are very confident with is the fact that face mask, hand hygiene are proven interventions for curtailing the transmission, which is the reason why we are doing this house-to-house engagement, trying to educate people that this is what you need to do to make sure that you stay safe and all that. It's one of the things that we have seen is lacking is local leadership. As a country, we have done well. The presidency has done well. Ghana Health Service has done well with this weekly or twice weekly communication at the national level. So in terms of leadership at the local level, we feel that there are gaps that need to be filled. And we have the district health administrations that are there, the community people listening to the local chiefs. You have churches that have, pastors and religious leaders with unquestioned authority. These are community mechanisms that can be mobilized to enforce the protocols that are coming up. So, for instance, what we are envisaging is that if at the end of the month or every 2 weeks, the district health administrations mobilize all the health providers in every community, whether you are private, quasi-government, or CHAG, and come together with the local chiefs and say that the health providers are saying that this is the data that we are seeing. These are the mechanisms. These are the numbers that we are seeing. And then the health directorate decide to say that take it up and say, henceforth, everybody who does this is what should be done. I think that we need to move into that if we want to prevent the community spread. That is where we need to go. Otherwise, as we all allude to, initially because of the zeal and enthusiasm, we had a lot of people accepting. But as we go down, the communication go down and all that, we'll have people not complying, and that is where we are likely to have a rebound effect. So,
Dr. Calys-Tagoe, talking about involving the community, which Dr. James Jia is alluding to, you have been one of those who's been making the case for us to involve our traditional authorities and rulers. I want you to make that point again. Why is it that we haven't brought them on board?
Well, why we haven't brought them on board, I cannot tell. But I strongly believe, like Dr. Dia is saying, that they have a very significant role to play. Because some of these religious and traditional leaders, like he rightly said, have unquestioned authority. And what readily comes to mind is what was happening in Asanteman when Otunfo lost his mother. And then he issued a decree that people should go to bed at 6 p.m. because the old lady was going to be laid to rest that night. And the whole Asanteman went to sleep. If we involve such a personality in carrying out this mandate of educating the public, I'm sure we would have very tremendous results. So I don't know why they have not been involved, but I've had people who say, well, they don't need to wait to be brought on board. They should offer to come on board. But then that is where leadership comes in. When people are not willingly coming on board, they may have their own reasons or reservations, but it behoves on leadership to bring them on board. So why they haven't been brought on board, I cannot really say, but I strongly believe that they have a lot of role to play in that regard, because then people who look up to them will listen to them more. It's okay to have the press briefings and the what have you in Accra. How does the message trickle down to our communities? It's okay for Ministry of Information to every week or twice weekly do these things. How about the man sitting in Gunkugu Yoyo who doesn't have access to those press briefings? How are we carrying that message and sending it down to the community? What are we using our information services van for? And I always say this, that I was bewildered when about a week ago, there was an announcement in my area about Zoom Lion coming to collect waste, only for me to come out and see they were using a COVID-19 branded pickup. When nobody has used that pickup to do community engagement or community education since this outbreak started. Was the COVID-19 car purchased for Zoom Lion to use for that purpose? So we are leaving gaps in there. People should be educated in the language they understand. And they should be made to realize that, yes, the restrictions are being eased because our economy must run, but not because we are out of the woods. Unfortunately, that communication is not going down well, because each time we get the impression that, oh, we are doing well because we have fewer active cases. And it leaves the wrong impression on the minds of people. So I think we should handle our communication very well by bringing on board all these stakeholders, because they all have a role to play. Thank you.
Now, with all that's going on, with the data not being available, we haven't done enough research to be able to say exactly what is happening. Dr. George, would you advise, and based on the theory that I brought up earlier, would you advise that we actually open the borders, the airport, and allow people to come in, even though, yes, we may be doing some tests?
Well, I think that is above my pay grade. But, but you know, I think the government's decision to institute testing at the border, I think is a good one. You know, because much as you know, we don't seem to be having, you know, a lot of deaths. You also don't want to open the floodgates for viruses from other communities to come in, you know, because it could happen that what may come in will be something that is a little different in terms of viral sequences and so on. That could, you know, cause more severe infections. So I think it's prudent to, when they do open, to do those testing. The question is how to make it efficient so that your airport does not become unattractive, you know, and people, the purpose for opening it, which is to boost the economy, you know, is not achieved. So I think they are looking at all of that, which is good. So what I'll say is, when it's opened, you know, at this point of the pandemic around the world, I think it's very prudent for them to do the testing before people are let into the country.
Dr. Calys-Tagoe, your take on that?
Well, I think I share the views of Dr. Kyei. I mean, we cannot have our country locked down forever. There are a lot of losses that we are incurring as a result of our airports and other borders being closed. So if government has the capacity to test on site and have results before people get into town, then that should be fine. Because the challenge has been the fact that when anybody comes in, we need to quarantine them for 14 days. That comes at a cost. And either the government is bearing the cost or the individuals are bearing that cost. But if we have resources to be able to test and have results immediately, then there will be no need. But it still is not very clear because this virus has a lot of unanswered questions. For instance, if somebody is exposed to the virus, how long does it take before they will show positive on a test? That is a question that is yet to be answered. And that should inform our policies going forward. Because assuming I got in contact with somebody on the plane whilst we were coming and we arrive at the airport, am I going to test positive at the airport? Maybe, maybe not. Then I am released into the community and then I turn positive. So with the number of unanswered questions, I think we should be guided in implementing some of these things. Thank you.
Dr. James, yeah.
Well, I think the previous speakers have said it, but there are lessons that we can pick from other countries who have, opened their airports. I think we must not gloss over. So that is something that is readily available that we can pick. But let me also touch on what Dr. Calys-Tagoe said. It's an important question. The number of days that it will take for somebody to test positive, because not long ago when the nurses that went to Barbados, all of them tested and they were told they were negative. But as we heard in the news, about 9 of them tested positive on arrival at Barbados. That is something that should really inform us as to whether or not we are going to open our airport, because there are a number of people who may test negative in their countries. But if you don't have that test that will give us results within, an hour or so of testing at the airport, then we are opening the floodgates for something that we may not be prepared for.
Kwame say, it's here this up. What do you make of we saying that we're going to open up the airports and allow people to come in, even though, yes, we're going to do some tests?
Well, obviously, I have an interest in this because, like I always say, this is the first year in over 2 decades that I've not been to Ghana at least twice, and it's already August. So I have stated my biases from a personal standpoint. But then again, from a professional standpoint, I also understand why the borders need to be shut and why tests need to be done. Dr. Calys-Tagoe has asked an important question, and that is the question around the latent period. What is the time span between when you first get into contact with a contagious person and probably get infected to the point where you test positive. There's a number of research papers on that. Currently, the school of thought is between 2 and 5 days. But again, it goes back to what Dr. Kyei was saying as well. We do not have any data on things like that from Africa. I mean, while everyone was talking, I was looking on PubMed and other things, and I was trying to get any data that was coming through around research, latent period, and you'd be shocked. I have only so far found one paper from South Africa, and even that, it is in collaboration with the Oxford University, and that's on vaccine trials and B and T cell training, which was what Dr. Kyei was talking about earlier. Apart from that, there's nothing from the continent, absolutely nothing, whether it is for treatment, whether it's for clinical trials. There are a few clinical trials listed on MedRx. There's one I've seen listed from Ghana. I'm not too sure whether it's Noguchi or KCCR, but I've seen one listed. But there's nothing. So it begs the question, if we're going to open these borders, we're going to be reliant on data from countries who have been doing all this research and have been testing. We know that the virus has behaved differently in those countries. Are we then going to be cherry picking and saying, oh, when it comes to allowing people in, we will forgo the differences that we've seen and use their data. But when it comes to managing COVID nationally, no, we would use local solutions. I don't think we can cherry pick that much. And so we need to start looking at how we would research these things and have information of our own to guide our decision-making around these things. Because I, for one, if I'm coming into the country and you're going to quarantine me for 14 days, I'm not going to come because I'm just not going to be able to come. Because when I get back into England, I've got to quarantine for another 14 days because Ghana is not on an air travel bridge agreement with most European countries, the EU, or Europe, United States. So I have to deal with 28 days of quarantine plus whatever time I spend in Ghana. It's not going to happen. The only way I'll be able to convince people is if there's some research which says that, oh, this is what's happening, this is how the virus is behaving, this is the testing protocol in Ghana, and if my employers and the UK government has an agreement with Ghana, then yes, I can travel. So for me, it's important to open up, but we need to open up properly.
Dr. George.
Yeah, I'm really happy about what Dr. Essiri is saying. You know, if you remember when the government took the decision to quarantine the travelers back in March, and we tested them at Noguchi here, and out of the 1,030 people, you know, 79 of them were positive at the first test. But, you know, when they completed their quarantine, the negative people, 26 of them had converted to positive. You know, so definitely if you are doing, you know, the testing, you are going to, even if you're doing at the airport, it's likely you are going to miss some cases. That one, I don't think is in question, but it would be nice if we had our own data on this, you know, so that we can say for sure, you know, that, you know, among, you know, Africans or so on, this is what you are likely to see. But because of the incubation period, you know, and also the latency period, you are definitely going to be missed on people because the virus has to begin to replicate for you to pick it up. Even with PCR, although it's very, very sensitive, you know, you still need some time to be able to pick it up. So you are more likely to miss some people who are coming in. But that is not to say we shouldn't test. You know, we should test because you probably catch the majority of people and miss a few, which I think is better than letting everybody in.
So at this point, I think we all agree that, well, the number of cases that we're seeing in Ghana has gone down considerably. But we all also agree that it doesn't mean that COVID is gone. So the question, or what I'd want to ask of you all, is how do you think we should approach this pandemic at this point? Yes, Dr. Calys-Tagoe has talked about the fact that our risk communication, we have to really pay attention to how we communicate. And there's also the bit about bringing on board the traditional rulers. So how do we go about it, and what would it take to bring on board the traditional rulers and all that you'd suggest? I'll start with you, Dr. James Jia.
Right. Thank you very much, Israel. For me, I think that the religious leaders is a group that we can target. And why do I say so? In Ghana, we classify about 71% of Ghanaians as Christians. Now, that is the reason why every Sunday you find that the streets are empty. Now, if we decide to target religious leaders, I mean, who I earlier said that they have unquestioned authority, that means that potentially we'll be reaching out to about 70% of Ghanaians in terms of risk communication. It's our people who talk and people listen to them. I have had occasion where I've told my own staff, send your parent to the hospital. You need to keep the parent there. The next morning, the parent was back from the hospital. Why? Because he says that my pastor says you should come home. And even though I'm a doctor, so it brings us back to the point that, Ghanaians are willing to listen to pastors, and we can leverage on that to reach out to the population. Again, we can use the imams and the Muslim clerics to also reach out to. So basically, let the experts decide on what to say, how it should be done. Let us leave that let us send it down for the religious leaders, the Muslim clerics, and then the traditional authority to send the information down. They are also the very people who can enforce the law at the local level. Thank you.
Dr. Calys-Tagoe.
Well, just to add to what Dr. Dia has just said, we also need to be mindful of how we interpret the local data that we have. I think it's very important. It's one thing having data, and it's another thing interpreting that data. And from a Christian point of view, if you take the Bible, there are different people who interpret the Bible differently to suit their various agenda. So one person who likes drinking will tell you the Bible says drink, but don't get drunk. So we can all interpret data in our own way to suit our setting. But in interpreting data, I think we need to carry the people along. Let them know the limitations within which we are working. Then it becomes easier to interpret it, and at the same time, get them to abide by the safety protocols that is being handed down to them. But if in interpreting our data, we are saying that there is no risk, and yet you encourage people to stick to the safety protocol, that sounds like a double standard, and it's difficult for people to comply. So let's be mindful of that. Thank you.
All right. Now, those who are watching us and who have been sending in their comments and their messages, I'd like to read some to you. And some of them, you may be in a position to answer Dr. George. So we have Bernard Togbo, who says, what was the percentage positive for contact tracing and routine surveillance? Dr. Franklin Yesiru-Bekwem may be in the best position to answer, but he's not, I don't see him on. So Dr. George, if you can help us with that. Then the test is not free, so a lot of people can't afford it. All right, but I thought tests are free, unless maybe I don't understand you. Okay, so Jojo Techi comes in and says, the test is free. The test is free if you report to a government or CHAG facility. And we have Joey saying, is this guy trying to gimmick his demigod? What has this got to do with NDC? I don't know, probably it's a very unrelated comment. Jojo Techi comes in again, which government, so Karen asked Jojo Techi, which government facilities are licensed to handle the test? Jojo Techi comes in and says, I don't get you. I thought I heard All right, that's also not quite related. And Winey says that's a reactive approach. We need a proactive approach. I'm not sure what exactly you meant by that. Now, Jojo Techi comes in and says, the Greater Accra Regional Hospital, UGMC, via the Lucy app for those mildly symptomatic and for those moderately ill, can go through the national telephone lines to be admitted to the right health care facility, Kolebu Teaching Hospital, and in many other hospitals in Ghana. And Jojo Techi also adds again, East Municipal Hospital. He also comes in and says, Karen, you can contact me if you need any further information privately. You don't want to hijack the platform, that's good. Thank you very much, Jojo. And Bernard says, the most proactive approach now is promoting the wearing of face masks and social distancing. Eileen says, wearing a face mask alone is not enough. It must go with social distancing, frequent hand washing with soap, avoiding touching and faces, and avoiding touching our faces and use of hand sanitizers. Wimi comes in again, Bernard Togbo. Unfortunately, we don't see people complying. And all right, so these are some of the questions that we have at the moment. Dr. George, do you have, can you answer the question about the number of, the percentage of positive for contact tracing and routine surveillance?
Yeah, I think that is actually they can check at the Ghana Health Service website is there. So the routine surveillance is 10.7% and contact tracing is 9.6%.
Right.
Yeah. So also to say something about the measures, you know, in intervention in medicine, there is something called bundling, you know, where you bundle a lot of different interventions for it to be effective. You know, so you can't say, as for me, I don't wash my hands, I'll just wear a mask, you know, or I'll wear a mask, you know, but, you know, I won't social distance. You know, it's when we do all of these things together, that is when it is effective. So we should really educate ourselves to say that, you know, let's do all of them. You know, you have to do all of it together. That is when it's going to be effective.
All right. Then we have Bernard Togbo saying people are dying from other diseases rather than COVID because of unintended consequences from overemphasis on COVID and also the fear factor. Is that really the case, Dr. George?
That is what I was alluding to when I said that, you know, our clinics are not as open as they should be. And if that is happening, definitely, if you have high blood pressure and you can't go and see your doctor, you know, you are likely to get a stroke or something else, you know, so that could happen. But again, you know, this is where, as a country, we need to get our act together when it comes to these things in terms of measuring, you know, how many more deaths have we had during COVID, let's say, compared to last year. That is the only way we can measure those things objectively. You know, so in South Africa, where there is data available, were able to determine that, oh, during this COVID period, the number of deaths that they've had, you know, compared to the same time last year was much, much higher, you know, even if you account for the number of COVID deaths. So maybe the epidemiologist here can say something about it, but these are things data that as a country we should have in hand all the time, you know, so that we can actually be specific on these things. But definitely, I believe the viewer that is definitely possible that is happening. But I don't know whether we have any numbers in Ghana that I have seen.
Right. Do we have any comments from you, Dr. Calys-Tagoe?
Well, just like Dr. Kyei is saying, it's difficult to put the numbers to it right here in Ghana because I'm not privy to the number of deaths. But talking about other health activities that may have come on hold because of COVID-19, yes. I mean, when COVID-19 started in March, when we had our first cases in Ghana, there was ongoing polio immunization in Ghana. That was stopped abruptly. So in that regard, people who were due to receive mop-up immunization would have missed out on that, and therefore such children risk getting polio. So in the same way, I'm sure there are other activities like child welfare clinics that may have been temporarily put on hold. So some children may have lost opportunity to be vaccinated. However, some of these things are returning to normal. But again, to be able to tell exactly whether people are dying more during this COVID period, we would need to look at our local data and tease that out.
All right. Now, the Jojo Techi, who is actually on Facebook and who was supporting, is actually Dr. Godfred Techi of the UGMC. So he's also on Facebook. He's watching us. Thank you very much, Dr. Techi, for joining us. I have this other coming in from Philibert. He says, as far as efficacy of locally produced herbal products such as sobolo, etc. are concerned, the onus is for the scientific community in this country to provide evidence to the contrary, or hold our guns and let them be. After all, we never approval from WHO to use Bentua down generations. Okay, I don't quite get the point you're using. You're saying essentially we didn't get approval from WHO to use Bentua, but you believe that Bentua works. All right, then Samuel says, but there is also the counter effects of some religious sects who might be promoting myths associated with their faith practices. So religious leaders are key to influence, but need management. How do we do this in a guided way? And this question should be for you, Dr. James. Yeah, you indicate that, yes, we should be able to use the religious leaders in the advocacy, but there are some religious leaders who are probably not preaching the right thing.
Yes, thank you very much. Before I answer this, let me talk a little bit on Dr. Benatobo's, comment on more people dying. We have tried to analyze our national data from the DIMS. Unfortunately, it's down since yesterday. But even without analyzing the data, it's straightforward. You know, initially there was this pressure to close facilities down because some staff have tested positive. The analysis is simple. So if you have a facility that receives, let's say, 20 emergencies a day, and you know that potentially every emergency case is a death case. So if you do close the facility down, it means that, all the 20 cases can die. If you do analyze also the number of deaths, annual deaths, and you close facilities for 2 weeks, 3 weeks, or whatever it is, that means that more cases are going to die. And as we are aware, Dr. Chase said it, that because of the fear of the hospital environment, that it's unsafe, a lot of the people are not visiting the hospitals, including even pregnant women. So even without going into the data, we are bound to have more deaths than we will have. That aside, on the issue of religious leaders spreading falsehood or whatever, that is why I did say that it is important to guide these religious leaders. And that brings in the issue of training and clearly communicating what should be communicated. Of course, those people should also be monitored. I'm sure that with the right training and guidance, they should be able to deliver what messages we want to get out into the community.
All right, we have a comment coming in from Samuel, who says, we, Caritas Ghana, are coordinating both Muslim and Christian faith groups for the purpose of influencing behavioral change by religious leaders, but we are still missing some religious sects. Question, do we have information on the impact of COVID-19 on mental health in Ghana? Is there a response plan? Yes, I know that there's been some work that's been done, or we're all privy to some research information on that, but I want to start with you, Dr. George, the issue of whether there's been some work done on COVID-19 and the impact on mental health.
Yes, not that I have not seen any papers on that. Personally, that is not my area of research, but I haven't seen any paper for Ghana. I've seen a manuscript that somebody was circulating on social media where they look at healthcare workers and the impact that COVID is having on them. And it looks like it brings a lot of stress and fear among healthcare workers, which one would expect. So yes, again, when it comes to mental health, I think the number of psychologists and psychiatrists in the country, very few, we have, I know somebody who does counseling, and that person has been overwhelmed, with cases of people who need help. And I've talked to a few people myself who became positive, and the amount of anguish that they went through and the amount of time I had to spend counseling them was quite a bit. So I think it's definitely something that is going on, and we should look at it even more carefully among our healthcare workers, to make sure that they are in the right frame of mind to take care of us.
All right, do we have any other takers? Otherwise, I'd want to bring in Dr. Esiedu Bekwe. There are a few questions that we have pending for him. Dr. Esiedu Bekwe, if you can connect your video and if you can hear me, I would want you to take some of the questions we've had for some time now. One of the questions we'd like to ask is, why haven't we brought on board the traditional rulers, or when do we intend to do that?
Let me say that we realized the import of national traditional rulers, and I remember a month ago we were in Kumasi, and we had a meeting with the regional director. So apparently he had an engagement with the Otumfo. So they've gone to see the Otumfo about how to clearly articulate a message to get the people to adhere to the use of the face mask. So we've actually clearly identified the need to get traditional rulers. So we're going to actually engage them more to make sure that people abide by what they say. So it's not just about the traditional rulers, it's about the church leaders. So you can see that there are some messages that going out, or some videos going around whereby prominent pastors are giving out messages about adherence to the safety protocol. So we are actually engaging them to make sure that people follow them. I think that earlier on, Calys was talking about the message. I think that this is a challenge, that you do not create fear. You also make sure that you don't create unnecessary calm, because when people think that the disease is gone, they may not wholly abide by it. It's a challenge and it's a trade-off. So I think going forward, that's why if you listen to the way I speak, I always talk about the fact that whatever we are achieving is basically based on we somehow adhering to the safety protocols. And we are going to stick to that and make sure that we permeate the mindset of the Ghanaian. I said that to add the synergy between the media, the health system, and then the average Ghanaian is what is keeping us. So all of us have critical roles to play to make sure that we win the fight against COVID. To me, looking at the data or the figures, we can see that we are doing well now than a month ago, but it has to do with sustaining the effort. I think at the point in time, there was issue about this the airport, and to me, I think the direction now is how do we ensure that we are not fully deflated by the COVID. So if you look at the direction we are going, we are gradually trying to open the airport, and we are looking at a two-pronged approach. One is the person entering the country must come with a PCR test, which is negative. And then when you enter the country, you also do an antigen test, which will be negative. So if you come positive at the airport, then you are sent to the treatment center. So that is the direction that we want to go. And we're actually trying to finalize the guideline. And hopefully in the next few week or two, we'll get our borders on course. To me, it cannot be full proof or full eradication of the risk, but it's about minimizing the risk to the barest minimum, that the chance of somebody becoming positive and entering the country is very much curtailed. I think that as a country, and I like your engagement. I think we need to engage the average Ghanaian more. so that it becomes very, very unpopular for you to walk around without a face mask. I think that when the media gets that agenda on course, when that narrative is that it's unwise or it's unpopular for you to walk around without a face mask, the average Ghanaian will tow it. It becomes a norm. Like now, it's about an abomination to shake somebody. Likewise, you can move that same agenda that you cannot walk around where 2 or 3 people are there if we are not wearing a face mask, and it cannot wholly be reliant on the health system. So we want to say that the media should help us in that drive to make sure that the use of face masks becomes the norm in the country. Thank you.
All right, please don't go yet. I see Dr. Kyei has his hand up, so I'll be coming to him. But I have a question also here, or a comment. Mary Ayibonte says, a myth is very true. My church does the COVID-19 education every Sunday to remind members of its existence. Other religious leaders think with faith we will not catch the virus. And then Paul Saul says, Israel, can you ask this question for me? Are we undercounting mortality from COVID-19 in Ghana? For example, suspected patients who died untested, are they counted? Dr. Franklin Siedu-Bequem, this should be your question.
Yeah, so normally if you look at our variables that we use to line list our death, there's a variable called date of death in this sample taken. So in some instances, the person with death, we are not sure of the results. When the results come and it's positive, it becomes a COVID-related death. So that's what we do.
All right. So Dr. George, I can now have you ask your question.
Oh yeah, I was going to say that, that also means if you don't get into a facility and you have shortness of breath and you are never tested, then you will not be counted, right? So you have to be tested to be counted as COVID positive. So obviously the number that is recorded will be lower than what actually happens on the ground, but that is kind of expected. I was going to say about the face masks is, if you go to Asia, they are very compliant, in wearing face masks. Do you even know why people know they have to wear it, but don't wear it? Where are social scientists? So all these things require some research, to be able to figure out what is going on. And we can assume that just shouting the message or bringing the police is going to solve it. It's not. So we need to really find out what is underlying all of these things so that our national policies can really be guided by good research that is from our own environment.
All right. Dr. Franklin Siedu-Bequem, are we able to pick up all the positive cases that the positives that are tested in the system? As in, because there are some private laboratories who are also conducting tests.
Yes, thank you very much. Let me say that I think because I went off, but I can foresee that there was an issue about counting the deaths. So I think there's this project or pilot we are trying to do is about the rapid mortality surveillance. The idea is that be able to establish excess mortalities that occurred that you can maybe attribute them to COVID. It's being done because it's not all death that you can be sure that it could be COVID, but you can attribute them to COVID. So it's being done. We started just a few weeks ago. Hopefully, give us an idea of possible people who could have died from COVID, which our normal system didn't capture. So that's one. The other issue is that we want to make sure that COVID is out of Ghana. So it's not just about figures. The idea, so we have gone ahead to make sure that the private sector is fully on board. As I said, we have brought MDS Lancet, Yahoo is on board, Akai is on board, Zipline is on board. So people can test, because it's when you test that you have an idea of the magnitude of the disease in the country. So first, you go to any of these labs which are accredited, and we have what we call a laboratory network who ensure quality assurance, so that if you are tested, it's positive and as positive. So as far as you're concerned, we want to be sure that the testing facilities are available and then there will be less challenges for people to gain access. If you look at the country now, northern Ghana, we have about 3, the middle belt, we have about 2, and then the southern, we have quite a number. And then we have tried to make sure that our reporting is more electronic. It's not wholly complete yet. In the time past, we used to do more of manual reporting. Now, we are doing more of electronic reporting. And we have trained all of our testing sites that if you pick a sample, then you use the barcode system that it gets to the lab, and then the lab just decodes the information, and then instantly the test result is known by all stakeholders at the national, regional, and the district level. So that is what we are practicing. We are hoping that, let me say that COVID has come with some advantage for us. Now, our data system is integrated. So the COVID burden that exists in Ghana Health Service is about the same that exists in Konfanochi or the teaching hospitals. So I think these are pluses that COVID has brought to bear in Ghana.
All right, we're just about wrapping up at this point, and I'd like to take your final comments. For you, Dr. Calys-Tagoe, your position is that, yes, COVID, yeah, the number of cases may be going down, but it doesn't mean that we should go lax. You believe that we should push the issue of wearing of face masks.
Yes, and I think that is our direction. The cases may be going down, may be the fact that we are doing the right things. So you can only sustain it when you maintain the right things and do it better. And one sure way of achieving that is the use of face mask, effective use of face mask. And what we want to be doing is to do regular surveys on the wearing of face masks, and then to give us an idea whether we are doing the right things. I want to make sure that the media is on board, so that if you are not wearing face mask, it becomes very unpopular activity to undertake in Ghana.
All right. Dr. Calys-Tagoe, I'd like to come to you. What would be your parting words for those who think that the active cases are going down and so, well, I can return to life as normal?
Well, I would want to say that, yes, the active cases may be going down, but there may still be transmission going on within our communities. What we don't know for a fact are the long-term effects of COVID infection, whether mild, moderate, or severe. And we should be mindful. 5 years down the line, what are we going to see as a result of people who may have even suffered COVID and were asymptomatic? And so as much as possible, we should all work towards reducing the transmission by wearing our face mask properly, washing our hands with soap under running water, and using hand sanitizers when water is not readily available, and ensuring that we maintain that physical distance as much as possible. We should let this message go around, and let's keep emphasizing that we are not out of the woods yet. Thank you.
All right, Dr. James Dua, for you, I'd want to ask you, because you're all experts in your field, you're medical practitioners. Well, Dr. James Dua, Dr. Calys-Tagoe, Dr. Calys-Tagoe, and Dr. George. Now, I want you to tell us, how is it that, or what is it that you do as part of your lifestyles that has, to ensure that you're COVID-free or you stay safe from COVID?
Right. Thank you very much. One of the things that I take caution of was when one of our colleagues was hit, one of our senior colleagues, the former rector of the Ghana College. That brought the message down home that, hey, everybody is at risk. And so much as sometimes we think that there are people who are more at risk, all of us at risk. And for me, it's also a way of telling my family and my workers and everybody that I come into contact with, everybody is at risk. And let me also say that at this point, I think we need all stakeholders on board. If I were the Minister of Finance looking at the figures, we have passed half the year, the economists, and this is facing us. Obviously, I'll be worried about how much the country is spending. And this is why I think that all the stakeholders must come on board. Much as government want to ease restrictions and other areas, we all need to be on board. As the other time we told you, even though we have FDA that is working hard to make sure that we are getting the right product. There are also unscrupulous people who are churning out a lot of products into the system. It calls for all hands on deck to be able to protect Ghanaians. And one of the things that has come out clearly for this meeting is the fact that we need a lot more research. And here we want to encourage the government to put in more money, because as it is, the advice and decisions that are being made presently is scientific based. And therefore, for us to go forward, we need to put more money into research. We know that there are very good researchers in Ghana who can do research to inform us as to the next step. So we implore the government to put in money into research. The other comment I want to make is that we have not optimized the platform that we have at the community level. And this is the point that we need to optimize all those platforms in terms of using our leaders, whether they are religious leaders, whether they are Muslims or the health workers at the community level. And then lastly, to say that hand hygiene is the single most important preventive measure. Yes, we put on the face mask, but we must also ensure that we are washing our hands. I am looking forward to next year when we can say that because of hand hygiene practices that were instituted this year, probably other diseases like diarrhea diseases have gone down dramatically for 2020. Thank you very much.
We're also hoping, I also hope same. So, Kwame Sierra-Sapong, is there anything you do especially that or that's peculiar in the things the way you carry yourself that keeps you COVID safe?
Well, I've become naturally an avoider of crowded spaces. I keep telling people that it is clear as it stands that though I'm not in Ghana, we're in a political season, and the politicians, by their inclination and display, are not prioritizing the public health of the individuals. I mean, you can see it from all parties. I wouldn't want to single out any of them, which then means that the onus falls on you as a citizen to protect yourself moving forward. And so one of the key things, avoid crowded places, social distance, wash your hands, wear your face mask. So if I take myself, my routine has become pretty simple. From home to the office, office to home. Even shopping, fortunately, where we do it online and it's delivered to our home, put in front of the house. When the delivery man is gone, it's picked and taken inside. It's about being very, very avoidant of contact that I needn't have. And I think that is the best way for all of us.
Kwame said, when the shopping is dropped, do you spray it? Do you disinfect it?
No. I mean, there is a school of thought that you should disinfect it. Others say you shouldn't disinfect it. The issue is that then we know that the virus can persist on the food for about 3 hours. But fortunately, again, because of the protocol in countries like ours, what happens is that the shops take good care of these things and ensure that they are good enough. So I don't need to.
Okay, so that's for you, the shops in the UK. Dr. Calys-Tagoe, what is it that you're doing, or what advice would you give to every one of us to ensure that we keep ourselves safe?
Well, like Kwame Sierra said, I also avoid crowded places. And I think we should all do that. Politicians have their own agenda, politics, and to a large extent, the public health has become of secondary importance. So we should be the custodians of our own safety and ensure that we are doing the right things at the right time. Thank you.
All right. And Dr. George, your final take.
Thank you. So, yeah, in the lab, I always tell my students that, you cannot hold somebody responsible for the outcome of your experiment. So it also comes with your health. You cannot hold somebody responsible for your health. So we as Ghanaians, everyone should be responsible for our own health. I think the message is out there. You have to wear your mask, So when I'm leaving home, I have my mask on. I have my hand sanitizer on me in my pocket. When I pay the toll, as soon as I open the car windows when I pay the toll, so that the whatever has coming may go out. I wear my mask. I sanitize my hands as soon as I give the money to the toll person, because sometimes they are not even wearing the mask, So when I go to in my office, as soon as somebody enters, whether they are wearing mask or not, I wear mine. What else? So so when I go to a place and I have to interact with somebody and they are not wearing a mask, I ask them, why are you not wearing a mask? And often, interesting thing is that it's not that they don't have one, so maybe the guy doing the mobile money or the fitter or whoever, they actually have masks. They are just not wearing it. So when I ask them, they actually put it on, So I think we should all do that. If you see somebody that you're going to interact with and they're not wearing a mask, remember that mask is not like 100% foolproof. It's much better if the other person is also wearing it, So if you're going to interact with somebody and they're not wearing a mask, ask them to do so. And then finally, I think that, we need to do more research. Government should put more money in. We have the human resources and the equipment and everything else, I think, in the country. And we can do the research that we need to keep our people safe.
All right, thank you very much to all of you. Dr. Joche, UGMC, Dr. Benedict Calys-Tagoe, Kwame Sedu Sapong, pharmacist in the UK, Dr. Franklin Yesiedu Bekwe, head of disease surveillance at Ghana Health Service, and Dr. James Dua of CHAG. I appreciate the time that you take to be with us all for this kind of advocacy. I wish you all a beautiful Sunday. And to the rest of you who are watching, you can go to my YouTube channel, and get to watch all the previous episodes as well as this one. And thank you, and have a good day.